time. And what prayer begins to do is to attenuate those stress responses. If those stress responses are activated too frequently or for too prolonged a period of time, again, a lot of literature that demonstrates that that can be detrimental to one's health. So those processes are attenuated. What becomes augmented is the parasympathetic functioning, and we get lots of goodies from parasympathetic functioning: pro-social behavior, positive affect. The anabolic processes of the body are enhanced, so it's restorative, reparative. And of course, the immune system, too, would be influenced in ways because of the intimate relationship between the nervous system and the immune system. The immune system's functioning is enhanced in ways that would promote health. As I mentioned, it's a different animal when we talk about intercessory prayer. So private prayer, personal prayer, we understand it. We understand the outcomes more so. We understand the naturalistic mechanisms, again, that provide the connection between prayer and outcomes. When we talk about intercessory prayer, we are talking about, again, prayer that's offered by an individual on behalf of someone else. Oftentimes, the intercessor and the recipient are separated by large distance. There may be an intercessor on the East Coast who's praying for someone in the Midwest or on the other side of the planet. And yet there's some data to suggest that health can be shifted in those individuals. So consequently, we're not sure if the phenomenon exists, we're not sure what the mechanisms are, so there's a lot of debate in the literature around even conducting this research. What I want to talk about today is 3 studies to set the foundation of, in part, why I went ahead and did my study on the non-human primates. I want to begin with Bird's study in 1988. There was some literature on intercessory prayer that occurred prior, but Bird's study was really the seminal piece of research that began the increased interest in intercessory prayer and led to the various trials that we've seen in the past 20 years. What Bird decided to do was take a look at the effects of intercessory prayer in approximately 400 coronary care unit patients. The trial was randomized, it was controlled, it was double-blind. Patients were aware that they were participating in an IP study. They were not aware whether or not they were receiving prayer, so they were blinded to that. The prayer was directed, and when we talk about prayer being directed, this would be instructions being given to the intercessors that they would pray for particular outcomes. It happens often, frequently in fact, that intercessors are given directions. There's little tracking whether or not the intercessors actually follow the directions, because people who are engaged in an intercessory prayer practice can pray in a variety of different ways for health and healing. But in this case, it was directed daily IP by a team of Christian intercessors only during hospitalization for these patients. They were given the patient's first name, the diagnosis, and updates on the condition of the patient while the patient was hospitalized. What Bird took a look at was a number of factors: length of hospitalization, new problems that may have developed in the patient, diagnoses, therapeutic events during hospitalization were assessed. Now, there were approximately 30 variables that Bird was looking at. So out of the 30 some odd variables that were looked at, there were a few that were in fact significant. The group that received the prayer was favored for fewer cases of congestive heart failure and pneumonia. They required fewer antibiotics, fewer diuretics, and less intubation and ventilation. Bird also created a hospital course score, and he stratified it by good, intermediate, and bad. And what Bird took a look at was numbers of new diagnoses, therapies, morbidity level, risk of death, and created this hospital course score, which was also favored in the IP group. Their course was better than the patients who did not receive prayer. For about a decade, there was little that was happening in terms of prayer research. The next study of some note is Harris's work in '99, driven in part by the fact that there had been no further IP research, and they wanted to replicate Bird's study to see what they themselves would come up with. They also used coronary care unit patients. The sample approximately doubled. It was close to 1,000. Also randomized, controlled. This was completely blind. It was triple blind. Patients and staff were unaware that a trial was even being conducted. So this was happening independently of any patient's knowledge or staff's knowledge. Once again, directed prayer daily, 5 Christian intercessors following admission. The prayer continued here for 28 days. The intercessors were only given the patient's first name. So they may have been given John or Mary, even though out of the 1,000 patients, there may have been multiple Johns or multiple Marys, first name only. The primary endpoint for this study was a score that was created by the research team, the MAHI CCU score, and MAHI is an acronym for Mid-America Heart Institute, the medical center where the study was based. And this primary endpoint was based on the hospital course score. They created their own measure out of a number of factors, from relatively minor occurrences like needing antibiotics to fairly major occurrences. For example, the patient died. Those outcomes were weighted, so antibiotics would have been weighted much differently, of course, than if the patient ended up dying. And there was no difference in terms of hospital stay, just like Bird's group. That didn't make any difference between the groups. However, looking at the MAHI CCU score, the weighted score, the IP group fared better. They also decided to just take a look at actual count of events, so an unweighted score, and compared the two groups. And once again, the group that received prayer fared better than the group that was not prayed for. Let's move forward a few years to the most recent trial that has gained attention in the literature, and that was Benson's study in 2006. It was the most ambitious undertaking to date to study the effects of intercessory prayer. The questions that this study posed were somewhat different than what we've seen in the literature to this point. Part of the interest of the researchers was to examine whether it was intercessory prayer itself or the knowledge or certainty of receiving intercessory prayer that would influence both primary outcomes, which were complications, relatively minor complications patients would experience, or secondary outcomes, which were more major events or mortality in CABG patients within 30 days of CABG surgery. The patients were aware that they were participating in an IP study. There were 3 groups of approximately 1,800 patients total, so about 600 patients per group. There were 2 groups that were uncertain of their receipt of prayer. Out of those 2 groups, one group received prayer, the other group did not, but both groups knew that they might possibly be receiving it. The third group was told they were receiving prayer and in fact received prayer. Directed intercessory prayer was provided for 14 days, beginning the night before surgery. There were 3 groups of Christian intercessors. There was no difference in secondary outcomes across the groups, so there were no major event differences, no death differences. If we took a look at the 2 groups that were uncertain about receiving prayer, there were no differences between those 2 groups. But in the third group that were certain that they were receiving prayer and in fact received it, there were significantly greater complications in that group when compared with the uncertain groups. We can also, of course, look to reviews and see what meta-analysis or a systematic review may tell us about the body of literature that's out there. The waters remain muddied if we look at reviews. The data is equivocal. The Cochrane collaboration conducted a review in 2008, and they summarized interpretation of the results can't be done with great confidence because indeed the data are equivocal. However, their findings indicated that there was enough evidence that further study into the effects of intercessory prayer on ill health would be justified. The other camp, Masters and Spielman's, are good examples of the secondary camp that essentially says this is a waste of time. We should not be spending resources, etc., studying intercessory prayer. Their meta-analysis indicated a very small effect size, and the efficacy of IP in healing didn't even approach significance. So let me summarize some of the criticism. This really is a highly contentious area of study. There's a lot of emotion we see in the literature driven behind the criticisms of these studies and so on. So I have a couple of slides of summary of that. The criticisms essentially fall into one of, I have 3 categories, but there could be 4. Theoretical, ethical, methodological criticisms, and there's also theological criticisms of even approaching this kind of work. First of all, we don't know if the phenomenon exists. So if we don't know